now I would request Dr. Sucheta Parija ma'am to discuss about the do's and don'ts in traumatic cataracts in children. Traumatic cataract in itself is tad different from that of a management of a normal cataract. So traumatic cataract management in children is definitely very challenging. Over to you, ma'am.
Good afternoon, all of you, and I thank the AIOS for giving me opportunity to speak on pediatric traumatic cataract do's and don'ts. I don't have any financial interest in this presentation. So all traumatic cataracts is more or like a surprise for us. We don't know how do they present to us. Children, sometimes they come to you saying that they don't know that they had any trauma or not also. So they can present to you with variety of morphological features where they can have associated corneal pathologies as well as posterior segment pathologies. You can see here they can present to you with a total cataract or with a membranous cataract, or they can have iridodialysis, and then when you go about doing investigations you can find that there are some other pathologies associated with it. So traumatic cataracts account for 29 to 57% of childhood cataracts, but what is important, the management is very challenging. And we have to take into consideration certain points, that age of the child and the risk of amblyopia in these children. And as we know, very small children, when they present to us, there is still an ongoing development going on. And then if we are tackling a cataract in the same sitting, the IOL power calculation, which also is a debatable issue and difficult to calculate in children, and then associated corneal and retinal pathologies. Along with that, we should also keep in mind that these eyes are risk for always having an increased inflammatory response. So preoperative evaluation is you should be very meticulous in that. If you see this case, child who is present to you, if you dilate it, you can see there is a corneal scar, there is a posterior synechia, there is a total cataract. But what is important, you have to look at the capsule, whether the capsule, there is even a small capsular rupture, whether it's there or not. If it is a frank rupture coming to you very early, well and good, you can very well know and do it. But these are certain things. Sometimes there is a sealed a capsule which will be there. There are fibrotic membrane which is associated. So all these are very important when you are going to manage these cases. So let's start with one of these cases. This is a child who just presented to us. You can see there is a total cataract and there is a corneal, already a sealed corneal tear. And what is happening, you see the fibrotic capsule. So it's very, very difficult. I was trying to do entire capsular excess, but it's still difficult. So we try to do maximum capsular excess. So take the help of your Otrata forceps, try to do it. And what is happening, we try to do more than 180 degree, but still there was a fibrotic membrane which was there. So what we did, we took the help of our microforceps scissors, and then just after doing it, we left 2 clock hours. And then since this child was around 4 years old, since the PC was intact, we had to do a PPC and give a intraocular lens. Coming to the second case, just 1 minute. It's not playing. Hello?
Somebody from the audio visual, the video
Please,
is not
it's
playing.
not playing that. So can I just go and do it? Okay. I don't know, I had told them to do it. Okay, this was a... So since I cannot show you, this is hyperlinked actually. It was not playing, so they did it, but still it is not playing. So coming to the third case, here another child who had come to us, and you can see there is a fibrotic capsule in this cases, and there is a total cataract. We could go about to do a complete rhexis in this cases, but what I wanted to show you is that look at this fibrotic posterior capsule which is also there. So what a lot of wrinklings and all. So even though child was 8 years old, we had to tackle the posterior capsule and tried to take out the fibrotic membrane which was there, because very important in this children is the vision axis clearing is very much needed, because anyway you do a good thing and then afterwards the amblyopia sets in. So there are certain protocols or certain things you should be taking into consideration when you are dealing with any traumatic cataracts, and especially in children. Better to avoid doing a IOL surgery, what I am saying, not a cataract, it's a IOL surgery during the primary repair. So any case who is coming to you with an open globe injury and you see a very clear-cut corneal laceration, better to do in the first sitting the corneal repair, and then you plan for doing a IOL in the second sitting. But if you see that a child is a amblyogenic, it's 2 years child, the patient cannot be taken repeatedly under GA, and you see the anterior capsule is already ruptured in these cases and the IOL is all the material is out, it is better to tackle then and there. Whether to put a IOL then and there, it is again a debatable issue, but after you have done a good primary repair, you can take up the cataract surgery within 1 week to 1 month. Amblyogenic age group is very, very crucial, because very important, you have to clear the visual axis. So presence of corneal wound decides your timing of surgery or putting in a primary intraocular lens, which we all know gives the best result. Posterior segment pathology, any iris damage has to be managed, and very important, once you give the IOL, send the patient, but you have to follow them up, because long-term follow-up complications are very important. There can be a rise of intraocular pressure leading to glaucoma. These eyes are anyway inflamed all the time. You have to give them long-time steroid dose, and posterior capsular opacification should be managed. So my take-home message is meticulous examination of each case is individualized. So all children have to be dealt with how they are going to presenting to you. Plan for the primary repair first and look for any associated ocular injuries. Planning for IOL implantation is very crucial. When you see there is a very bad corneal wound and you cannot calculate the IOL power, you can take the IOL power of the other eye, but visual rehabilitation and management of complications is a continuous process. Thank you.
Thank you, ma'am, for your